Good morning, everyone. Distinguished guests, ladies and gentlemen. It is an absolute pleasure to be here. Thank you ever so much to the Stans Foundation for the invitation. It is my first time to Taiwan, and I've had an absolutely lovely introduction to the country and the healthcare system, so I'm delighted to be able to speak to you today. My name is Charlotte Roberts. I am a medical doctor by background at the International Consortium for Health Outcome Measurement, ICHOM. I studied medicine in London. I've practiced as a doctor, and at ICHOM I'm now Vice President leading our standardization efforts, measuring outcomes that matter most to patients. Today I'd like to introduce you to what ICHOM stands for, value-based healthcare. What is value and what is an outcome? I'll introduce you to our standardization work and the standard sets for which I've been delighted to be working with Professor Chen for the past 3 years to develop a standard set for older persons, identifying the outcomes that matter most to older persons so that we can measure them and ensure that our healthcare systems are most designed for those that need it most. I'll also touch on how we actually measure outcomes in organizations and how we're moving towards benchmarking, being able to compare between countries, between organizations, so we can identify the best care and learn from others around the world. The reason we exist is because in many healthcare systems around the world, we spend a lot on healthcare. In fact, those numbers are increasing year on year, and that's not very sustainable. What do we get for those increasing costs? Does life expectancy always increase? Not always. Our spending is going up and up and up, but it's very hard to know what we get for the spending that we are putting into our healthcare systems. We also know that there's a lot of variation around the world. If you go into a hospital in America, you may have a 2 times difference in surviving a heart attack after being in hospital. If you have a cataracts operation in Sweden, there are 36 times the difference in complication rates. There's a lot of variation in care, and this is just the variation that we know about within countries. We can't compare between countries always because we're measuring different outcomes. We all have different definitions for what an admission to hospital is, readmission, quality of life, and it's very hard to compare like for like. So ICHOM is founded on value-based healthcare, a concept which was brought together by Professor Michael Porter in 2010. The fundamental goal and purpose of healthcare is to improve value for patients. Now, what do we define value as? Well, not just the process, not the number of appointments, but the results or the outcomes that matter most to patients over the cost of achieving those. In many sectors around the world, we would never look at the process as a marker of quality. But in medicine, we very much look at the process and not the results that matter. We count the number of operations, but don't say how well those operations have gone. So value is really the only goal that can unite the interests of all the system participants in a healthcare system. It's the most powerful single lever for reducing cost and improving value to improve outcomes. I'll talk through, but this is a really lovely example of why it's so important to understand what matters to patients. And these graphs are looking at outcomes associated with prostate cancer. So prostatectomy, an operation to remove the prostate gland, which is one of the treatment options for prostate cancer. And we're looking at results across 3 regions: Germany, across Sweden, and one clinic in particular, the Martini Clinic, which is one clinic based in Germany. And if we just look at this graph on the left, we're looking at 5-year survival. So after 5 years, is the patient still alive? And if we just look at those 3 graphs, everyone's achieving about the same. So you'd think, well, it doesn't matter where you go. Wherever you go, you will have the same quality of treatment. Now, of course, survival is very important. But you ask gentlemen with prostate cancer, what else is important? Incontinence, erectile dysfunction. We never usually measure that. When you do, suddenly you get huge differences in some of these complications. Now, not only do these complications have a burden on the patient, they also have a cost associated with them. So this really highlights that we should always ask the patients, what is important to you, and measure that, and measure it in a way that we can compare across different countries. So ICHOM was formed to be a catalyst for driving value-based healthcare. We were founded in 2012 by 3 organizations: Professor Michael Porter from Harvard Business School, Boston Consulting Group, and the Karolinska Institute in Sweden. And we're founded as an independent, non-profit organization to unlock the potential of value-based healthcare by defining standard sets of outcomes that matter most to patients with different conditions and driving the adoption and reporting of these outcomes worldwide so that we can improve our care. I've mentioned some of the leaders on our board, but I also wanted to mention one of the new additions to our board, Professor Don Berwick, who is one of the founders of the Institute for Health Improvement in the United States, as we really now move towards not only measuring outcomes, but acting on them. How do we improve them? How do we learn from them? How do we learn what's happening in Kenya and apply it to other countries? So what parts of the healthcare system are outcomes important to? Well, we believe that outcomes are important for every part of the healthcare system. As patients, we want to be able to choose our doctors, our hospitals, based on the results. If somebody asks me, where in the world would you go for cancer care? I have no idea where the best place in the world is because we don't have the outcomes evidence. So really being able to choose your provider based on the outcomes that they achieve. For doctors, we want to be able to learn from each other. We want to know, are our treatments working? How can we improve them? What can we do if they're not working? As hospitals, we want to be able to compare between hospitals and understand, why does that hospital have less infection rates? How can we learn from them to improve our care? As payers, we want to be able to not just pay for fee-for-service, but actually pay for results. So not just paying for a number of appointments, but actually the results that those appointments achieve. So not quantity, but quality. And then life science and industry. We've already mentioned AI, wearable devices. They're very much part of the equation. We want to understand how these new innovative technologies can actually deliver the results that are important to patients. At ICHOM, we have various departments. We're a very small team. We're 25 people in London and in Boston because the power of value-based healthcare is not in our little offices. It's around the world. It's in institutions. It's empowering patients and doctors and every part of the healthcare system. At ICHOM, we have various stages in our strategic agenda. The first is the what. What outcomes do we measure? How do we understand what is important for patients? And how do we measure that in a way that can be compared across countries? Next, we have, how do we measure outcomes? In all of our healthcare systems, we don't have much time. We have very pressured healthcare systems. How do we fit measurement seamlessly and easily into our systems such that everyone can use and benefit from the data? We've also moved into benchmarking. We now pilot our benchmarking program, comparing outcomes from different countries around the world. And then we move to really understanding the value. How can we use the outcomes to pay for services based on the results and not just volume? I've mentioned outcome a few times, and there are definitions around the world as to what an outcome is. There are very many acronyms, PRIMS, PRAMS, PROMS, CRIMS. It's an entire new language. But at ICHOM, we believe outcomes are the results that people care about most when seeking treatment, including their functional improvement, the ability to live a normal, productive life. And why is outcome measurement essential? It really defines the goal of an organization. No doctor goes into work to do lots of paperwork. They go into work to save lives and help people. So it really defines the goal of an organization. They can help inform the composition of the team that is going to help deliver the outcome. They can highlight value-enhancing cost reduction. Good care is a lot cheaper than bad care. Outcomes can motivate clinicians to collaborate and improve together, and allowing us to enable payment to shift from volume to results. I always say where outcomes fit into the process. If you imagine a patient goes into hospital after a stroke, for example, they will be subject to various processes. They will see staff and structure in a hospital. They will have an experience how clean the hospital is. They may have various tests, an MRI, a head scan. But then, this is then the outcomes, the results that matter. Can they stand? Can they hold a cup of tea? Can they go back and live independently? So this is what I mean by an outcome. How can we use outcomes? Well, we believe there are 3 primary ways to use these outcomes, although there are many, many more. Direct clinical care, being able to understand how is the patient doing today? What are their outcomes right now? How do we know if their treatment is working? We can ask their outcomes before a treatment, after a treatment, to really understand how a medication or a device can help that person. How do we know when, for example, a knee replacement might be best used? And how can we help our patients make better decisions and be more informed around the choices between chemotherapy versus palliative care? Comparison and benchmarking. As a doctor, how can we measure what we're actually doing? How can we compare that with other countries? How can we use quality improvement methods to improve our care? And how can we choose the optimal provider for any condition? These are more of the individual levels of data, but then we also have system-level uses of data. How can we build entire healthcare systems around delivering the value for patients? How can we design better research studies looking at outcomes that matter to patients? How can we assess if a new medication is truly effective? And how do we determine acceptable quality and improvement guidelines? So outcome data has many uses and is very valuable. And many healthcare systems around the world are taking very bold steps to reform around value-based healthcare. In fact, just the internet searches have increased hugely over the last few years. We see the Office for Economic Cooperation and Development committed. We now have a collaboration with the OECD to work together. Their ministers are very supportive of value-based healthcare because they see the cost of healthcare going up and up and up and want to understand the value of our healthcare systems. We see many countries moving towards paying for value, so outcome-based payments for different services in the Netherlands, in Israel, in Wales. Our standard sets, we've developed now 23 in different conditions, such as localized prostate cancer, coronary artery disease, inflammatory bowel disease, and our older persons' work. And is our work being used? Well, yes. There are many countries across 650 organizations and national registries which are measuring our standard sets. As I said, the OECD is committed to driving value-based healthcare and supporting countries, and organizations to measure what matters most to their patients. As a non-profit organization, we're very grateful for the support of many organizations around the world. And I also show this because it demonstrates the interest from organizations in driving this work. And we're supported by not only providers, payers, national governments, patient organizations, charities, and we have a life sciences program as well. So how do we develop a standard set for example, older persons? Well, I am a doctor and I've done a lot of work in outcomes measurement, but I've not been working in geriatrics for 20, 30 years. So we bring together an expert working group for each of the conditions that we develop a standard set for. And the group comes from a wide range of countries. In fact, throughout our 23 standard sets, we've had representatives from over 44 countries. And we also work with many patient organizations and patients themselves to understand what is important to you. Not what a doctor thinks is important, but what is important to the patient. We have a very structured process for developing each of our standard set. Our working group will attend video conferences and teleconferences, many of which are at very inconvenient times given the people that are joining around the world. And we will spend about a year together developing a standard set, understanding what outcomes could we measure, what is important to patients, how do we define that in a way that we can compare, how do we understand the evidence and the existing literature, existing efforts, registries, audits, and how do we bring in patient input and external consultation. This was the older persons group that we brought together, and of course you'll note Professor Chen, who was integral to developing this work 2 years ago, and I was in fact the project leader who led this. Over a year we came up with a standard set for older persons, understanding what matters most to our older population and how can we measure that across countries. I think the first challenging question around the world was, how do you define old? It's not an easy question, and what is referred to old in one country is not the same as others. So we had to be very innovative to even identify the scope. And to give some examples of the outcomes, you'll recognize some, but I want to highlight, we asked patients what was important to them, and you won't see grip strength or sit to stand speeds, but loneliness and isolation. There is increasing evidence that loneliness is incredibly important and can have significant impacts on your physical and psychological health. In fact, in the UK, we now have ministers looking into the impact of loneliness and designing programs to reduce loneliness. So really innovative area that is increasingly important. The activities of daily living, being able to stay in your own home, being in pain, your physical and your psychological health, having the ability to make your own decisions around where your care is, staying in your own home and being in charge of your own destiny. We also think about not only the older person, but the care of their carer, making sure that the person who looks after them has a good quality of life. We want to ensure that they are involved in any decision making, and also measure things like frailty as an outcome. Frailty is a very interesting condition which isn't always recognized as a medical condition, so we've recommended using it as an outcome for this purpose. We also recommend measuring the time spent in hospital towards the end of life, the overall survival, and the place of death. Where would that person like to spend the last few days of their life? That will vary around the world. But has that person been able to choose and make that decision known? So a mixture of very different outcomes, which together form our minimum standard set. Now, of course, this isn't every outcome you could measure. There are thousands of outcomes. But this is our minimum standard set that we recommend that can be kept and measured across multiple countries. We also use different types of information. So we ask clinicians for their reports, but we ask patient-reported outcome measures, PROMs, to get the patient's direct report of their own health. In addition to the outcomes, we also recommend case mix adjustment to ensure that we can make meaningful comparisons between different populations. For example, demographic factors, age, sex, level of education have a huge impact on these outcomes. And also baseline clinical factors. How unwell is the person to begin with? What other conditions do they have that will affect their care? To standardize the outcomes, we not only need to think about the what and the definition, but when do you measure outcomes? For an older person, how do you know when they're going to be in hospital? They could attend 30 outpatient clinic appointments a year, or they could be very well. So we really had to think innovatively around how to measure outcomes in a way that can still be compared, but still useful for example, analysing interventions, a falls programme, for example. I know the text is very small, but I highlight this because we use a lot of existing patient-reported outcome measures, and we look at a lot of options to choose the right PROM. The main tool that we used has actually already been translated for Taiwan, so that already translations to be able to compare with other countries. As a non-profit organisation, all of the work that we do is available on our website for anyone to use. We produce a flyer, a reference guide with definitions, compatible with electronic healthcare systems, and also our publication was just accepted a month ago for this work. So now I'm going to briefly talk about how we actually measure these outcomes, because it sounds very easy talking about which outcomes, but actually it's very difficult introducing this into a system. At ICHOM, we support many organisations. In fact, we're currently supporting 43 organisations to measure outcomes in their own system. Every country, every hospital is very different and has a different way of measuring data. But what the constant is the outcomes. Regardless of where you are in the world, if you're having a knee operation, you don't want to be in pain, you want to be able to walk. And that's really why we standardise the outcomes and not the process. From our implementation support, we've learnt that there are certain lessons that we need to learn. Leadership is critical to success. You need leaders in healthcare systems to really be innovative and drive this work. Outcome measurement is a team effort. It requires the entire clinical team to come together, to work together. There is no one-size-fits-all option. For measuring outcomes in Boston, in Nairobi, in Tokyo, there's a different system and a different method for every country. So we need to make value-based healthcare and outcome measurement work for every country. It doesn't have to be burdensome. We want the data to be useful. It needs to be accessible to all those who are working with the patient to be able to use it. It's not just another tick box exercise or data that goes into a cloud. It's for using in a day-to-day way. Because we want to action it. This isn't just data that's going to be in a report. We want to use it for the patient who's sitting in front of us right now. We're seeing increasing impact of our work. Some of our earlier standard sets, we see the outcomes being measured to conduct comparative effectiveness research in different types of treatment. We see our coronary artery disease work used in Australia, India, America, to really understand the impact of rehabilitation after a heart attack, to improve the diagnostics of heart attacks. For example, our lower back pain set, we see studies of the quality of life of longevity of spinal procedures, and also for making efficient referrals and reducing waste in healthcare systems. So not MRI scans for everyone, but really understanding the results that matter to patients so you can reduce waste in healthcare. And at ICHOM, we're really trying to highlight the stories of how outcome measurement is done so that other organizations and countries can learn. How in the Netherlands, they looked at all of their colorectal outcomes across the different hospitals and got together and discussed them and learnt how to improve some of their outcomes. How did an outpatient clinic in Wales introduce Parkinson's disease outcome measurement? And we're seeing increasing impact and benefit from measuring outcomes. And I've just selected a few examples. For example, there is a Cystic Fibrosis Foundation, a patient registry in America. And since 1995, which is when they started measuring their outcomes, they've seen a reduction in infections, a very nasty bug called Pseudomonas, by 14% by just looking at their own results. In Sweden, for example, between 1998 and 2009, the average 30-day mortality rate for patients who had an acute heart attack decreased by 65%, and a one-year mortality rate decreased by 49% by just looking at their own registry data. So it's very important to understand and look at your own outcomes. Finally, I'll just talk about our benchmarking program. We've now been able to start benchmarking in two conditions, cataracts and hip and knee osteoarthritis, being able to compare organizations across different countries because we're all measuring the same outcome that matters to patient. Now, this isn't about ranking. We're not naming and shaming. This is around understanding who's getting good outcomes and how can we learn from them and apply those lessons elsewhere. And in fact, we've had 66,000 patients involved from over 13 countries and over 78 sites to understand and measure outcomes and produce reports. At the moment, we're sharing these reports with the organizations so that they can understand their own data. And we hope to expand these programs to other areas such as older persons so we can start comparing across countries and understand how we can improve outcomes in other areas around the world. Thank you very much for your time today. It's an absolute pleasure to be here, and I wish you the very best for the rest of the day. Thank you.
Thank you. Thank you, Charlotte.